Greetings to you all, ladies and gentlemen. I'm your host, Dr. George Xavier Kuozo, and welcome back to our session of the Krok questions. So I'll be continuing from where I left off last time, which was on question 12, and we're going to be starting off with question 13. So with question 13, for me personally, there's not much information I could get. So basically, this is just going to be a cram question. I'll just read it for the sake of simplicity, but it's just going to be a cramming question. So Carrie's mobility rate is 89% among residents of the community. It is determined that fluorine content in water is 0.1 milligrams per liter. What preventive measures should be taken? So A, for fluorination. So this is just basically a cramming question. I'll move on to the next question, which is question 14, which is going to be discussing burns, which is a question I'll be explaining a bit more thoroughly than the previous one. Alright, so as you remember from the last videos or last sessions, I always recommend to start from the last part of the question because it'll help you understand what you're going to be seeking for, what sort of information you need to be aware of in the question. So the last part says, what is the provisional diagnosis? So you know you're looking for a diagnosis in this case. Alright, so let's start with the question. So the patient received flame burns on both hands. So you know that both hands are affected. And then the dorsal and the palmar surface of the hands, they are blisters filled with serous fluid. So the dorsal aspect and the palmar aspect are blisters with serous fluid. And then the wrist joint or the wrist region is hyperemic, and the forearms are not injured, which is good. So the wrist joint is hyperemic, and then forearms were not injured. Wrist joint is hyperemic, and forearms were not injured. Alright, so our answer is that it's a second degree burn of the hands, 4% of the body surface area. So in general, I agree with the term that it's a second degree burn, but in terms of assessing the total burn surface area, I'm not too sure what criteria was being used by the people that made the Krok questions. But I will discuss the general burn surface area, how I know it and how I was taught and how I use it in practice actually. Alright. Sorry, give me a moment to exit drawing. Alright, so as we can see, so we'll start off from the beginning, what are burns. So after chemical mass casual incident or trauma without burns is expected to be common. So burn therapy adds significant local logistical requirements and complexity to the medical response in a chemical. Alright, burns complicating. Okay, alright, so I'll skip this part because it's a bit too general and I don't want to waste much of your time. So let's discuss the diagnosis of burns, which is more important for us. So by definition, a burn is the partial or complete destruction of the skin caused by some form of energy, usually thermal. So besides thermal burns, you can also get chemical burns or electrical burns, but usually, as I said, it's thermal. So the burn severity is detected by the percentage of total burn surface area involved. So burns that have more than 25 or 20 to 25% total burn surface area required IV fluid resuscitation. And then if the burns have more than 30 to 40% total burn surface area, they may be fatal if they don't have treatment. So in adults, basically we use the rule of 9s, which is to say that the head and the neck compose 9%, and then the anterior trunk is 18%, posterior trunk is 18%, and then the arms, including the hands, would be 9%, and then the legs, including the feet, is 18% each, and then genitalia is going to be 1%. And then, alright, so let's just, since we're discussing the adult, I'll show you here as demonstrated in the picture. So the head and neck, as you can see, is going to be 9%, the trunk anterior is 18%, and then the posterior aspect is 18%, and then the arm is going to be 9% for each, and then the leg, each leg is going to be 80%, and then the genitalia is just going to be basically 1%. Now if you want to use, I would say, a more accurate or more specific, you would be using this count. But in general, the rules of nines helps you to make a quick assessment. So a more specific one would be this way: by the neck is 1%, and then the posterior would be. Alright, so as I was saying that when you're using these other two diagrams, it would be a more specific count. Or let's just read up the how to assess total bone surface area for children. So in children, you need to adjust percents because they have proportionally larger heads, which can be up to 20%, and smaller legs can be 13% in infants compared to others. So the land broader diagrams improve the accuracy of the total bone surface area for children. And then the palmar hand surface is approximately going to be 1%. Let's just see what age was our patient. So they don't mention the age of the patient in this case. Maybe the patient was a child. I'm starting to think about it, so it would make sense for it to be 4%. Anyway, so B is a more detailed elaboration or illustration of various percentages. So 1% for the neck, 2% for the upper arm, the forearms 1.5%, and then the palmar surface 1.5%, and then where it's written A, B, and C, it will be half of the head would be adjusted according to the age. So for children 0 to 1, 5 to 10, and 15 years. So you can read more about this to understand it way better. But in general, the rules of lines is what I usually prefer to use in practice, and it's a much quicker way of helping assess the total bone surface area. Alright, so move on to the next thing, which is basically discussing or understanding the depth of the injury, which is where we can talk about severity. So superficial burns usually are first degree, and then we have first degree and then superficial second degree burns. So for the first degree burns, the damage is above the basal layer of the epidermis, and then it can be dry, red, and painful. So usually this is a sunburn. And then for the second degree superficial, it's going to be damage into the dermis, the skin adnexa, which are the hair follicles, organelles, and other structures remain, and then heal by re-epithelialization from the skin adnexa. And then the deeper the second degree burn, the slower the healing, because floor adnexa will be present for re-epithelialization. So I think that's straightforward and a bit logical. So what you would see on the objective examination is that you would have a moist red blanching blisters, which would be extremely painful. So superficial burns approximately heal by re-epithelialization, and they usually take about 2 weeks, and then they don't heal with any scar tissue. And then the next classification is the deep burns, which can be deep second degree to the fourth degree burns. So deep second degree is also called deep partial thickness. So yeah, these depending with the literature you're using, it can have different names. Alright, and then damage to the deeper skin, less moist, less blanching, and less pain. Healed by scar deposition, contraction, and limited revitalization. And then third degree burn, which is full thickness, is just the entire thickness of the skin would be destroyed into fat in any color, white, black, red, or brown, and then dry, less painful dermal plexus would be destroyed. Healed by contraction and scar deposition because no epithelium left in the middle of the wound. And then fourth degree would be a much deeper, more severe one, which would be burning the muscle, the tendons, and the bones. And then this would definitely need specialized care. Usually grafts do not work. And then deep burns usually need skin grafts to optimize results, lead to hypertrophic scars if they're not grafted. Now, looking at age, mortality for any given burn size increases with age. So children or young adults can survive massive burns, and children require more fluid per total burn surface area. Elderly may die from small burns. The other reason why I think elderly can easily die from small burns is because they're already much more dehydrated compared to younger children, for example. And then smoke inhalation injury doubles the mortality relative to the burn size. And then associated injuries can also increase the severity. Any delayed resuscitation, delay increases fluid requirements, and then the need for sclerotomies and fasciotomies increase fluid requirements. Use of alcohol and other drugs, especially methamphetamine, makes resuscitation a bit more difficult. Alright, let me see if there's anything else I want to go through here. So, alright, so basically this is the criteria that is used by the American Burn Association unit for admission. So depending on where you are, the rules and regulations might be different. So in general, any second degree or third degree greater than the 10% of the total burn surface area under the ages of 10 or over the age of 50, any second degree or third degree burn than more than 20% in other age groups, and then second degree or third degree involving special areas, and then special areas include the face, hands, feet, genitalia, perineum, and major joints. Now, third degree burns greater than 5% of the total burn surface area in any age group. Electrical burns such as lightning, chemical burns, inhalational burns, burn injury in patients with pre-existing conditions could complicate management. Any patients with burns and concomitant trauma such as fractures or blast injury, where burn injury poses the greatest risk of morbidity and mortality. In such cases, if the trauma poses a greater immediate risk, then the patient may be treated initially in a trauma center until stable before being transferred to a burn unit. Now, physician judgment will be necessary in such situation and should be in concert with the original medical control plan and triage protocols appropriate for the instance. Hospitals without qualified personnel or equipment for the care of children should transfer children with burns to a verified burn center with these capabilities. Alright. Okay, I'll just move on to the treatment. We'll just discuss it shortly. What I think would be necessary. Alright, so airway, breathing, circulation. Yes, it's a bit extensive to discuss everything. I just wanted to mention one of the formulas that are used for resuscitation. So, for example, I would highly recommend you guys remember that about the Parkland formula, which is commonly used for IV fluid resuscitation. So the fluid of recommendation is usually isotonic fluid. In this case, lactated ring solution would be recommended, and fluid calculation would be as follows. So it would be 4 times the weight in kg times total burn surface area. So we give half of that volume in the first 8 hours, and then give the other half in the next 16 hours. Despite the formula suggesting cutting the fluid rate in half by 8 hours, the fluid rate should be gradually reduced throughout the resuscitation to maintain the targeted urine output. So do not follow the second part of the formula that says to reduce, just adjust the rate based on urine output. For example, you have a 100 kg man with an 80% total burn surface area. So you'd multiply 4 by 100 by 80 and you'd get 32,000 milliliters. So you need to give the first half in the first 8 hours. That will be 16,000 in the first 8 hours. The starting rate will be 2,000 milliliters per hour. Then adjust the fluid rate to maintain urine output of 50 ml per hour. And then albumin may be added toward the end of the 24 hours if not adequate response. So remember that albumin as a colloid, colloid would help to increase oncotic pressure in the extracellular space or in the vascular region. Alright, let's see if there's anything else that I'll recommend. Alright, so the other stuff you can just write notes and read by yourselves. Alright, I'll just scroll down to the last bit and you can just pause in between. Alright, let me just show you another picture I got for you guys, which would be a depiction showing the visual appearance of the various stages that we can have. So as we say, superficial burn, or then for superficial dermal thickness, mid dermal thickness, deep dermal thickness, and full thickness. So as I said earlier, that depending on the literature you use, they might use different names, but first degree, second degree, and third degree are usually common all around. So as I said, the first degree involves the epidermal layer, usually a sunburn. Appearance is dry, red, blanched pressure with no blisters, may be painful. Circulation is normal and can be increased. The color will be usually red, warm, and then no blisters, or they may appear later with desquamation. Usually healing takes about 7 days, within 7 days, and there's no scar tissue. And then second degree, but the superficial dermal thickness one involves the epidermis and the epidermis, and most adnexal structures are intact. So you'd be getting a pale pink or smaller blisters and a wood base that blanches with pressure. So increased sensation, very painful and tender and hyperemic. Rapid capillary refill. In terms of the color, it's going to be pink. Blisters, yes, will be present, as with our case. And then healing will take 7 to 14 days. And then scarring, there's low risk of hypertrophic scarring. And then mid dermal thickness, or this type of second degree burn, is in between the superficial dermal thickness and the deep dermal thickness. So the deep dermal thickness involves the epidermis and a significant part of the dermis. Only deeper adnexal structures are intact. So it's going to be blotchy red and deep pale, a deeper dermis where blisters are ruptured and decreased sensation. Sluggish capillary refill, so you wouldn't be expecting it to be hyperemic. White, pale, blotchy red. Now usually large blisters which rupture rapidly and slough off and over 21 days, and then a higher risk of hypertrophic scarring. And then epidermis, dermis, and subadnexal structures. And in the third degree or full thickness, these structures will be totally destroyed. There'll be white, waxy, charred, probably no blisters and no capillary refill, no sensation. You understand that since you have destroyed the innervation, you wouldn't get any sensation. And then circulation would be nil. In terms of color, it can be white, charred, or black. Remember, the epidermis and the dermis are destroyed, so there's no blistering present. So, and then healing does not occur spontaneously. As I mentioned earlier, you also need to include some specialized therapy, and then wound contraction and the higher risk as well for hypertrophic scarring, and it always heals with secondary intention. So, going back to our case, it's going to be a second degree burn, and then 4% in terms of burn surface area. As I mentioned, that it will make sense if the person was a child, for example. Let's just scroll up. If the person was a child, because if you're going to be adding these percentages, so 1.5 by 4, it will give you 6%. So this is the only answer that's closer to 6%. So you wouldn't need to choose 2% because that's a much lesser number compared to 4%. Alright, so moving on to the next question, question 15. So the question says, the complex of symptoms indicates the initial stage of chronic intoxication with which substance? Alright. So what we have is so during a periodic medical examination, an assembly fitter, so the job or occupation of the patient is important. This patient is an assembly fitter who works on soldering details. They didn't report any heart problems earlier, but closer examination revealed signs of asthenic vegetative syndrome. So asthenic vegetative syndrome. Blood included red blood cells with basophilic aggregations. And somewhat a high number of reticulocytes. And high concentration of delta aminolevulinic acid. So the complex of systems intoxication is okay. So if you want to cram and you don't really want to understand the pathophysiology behind this question, what I would advise for you to remember is delta aminolevulinic acid, because this is a compound that is highly related to lead poisoning. Alright, so we have a patient with a high concentration of delta aminolevulinic acid in the urine, which would be suggestive of lead poisoning. So the basophilic red blood cells, which means that they have numerous basophilic granules that are dispersed throughout the red blood cells, which is basically indicative of disturbed erythropoiesis or problems with erythropoiesis. So the testing of the blood and lead poisoning by basophilic aggregation method is based on the fact that the developmental period of red blood cells within the bone marrow may be interrupted under various conditions, thus producing basophilic aggregations. So for the sake of remembering or getting the question right, remember delta aminolevulinic acid, and the next thing you need to remember is basophilic aggregations, which should be highly indicative of lead poisoning. Alright, so we'll move on to the next question. Question 16. So it's asking what is the most likely diagnosis. Alright, so we have a 29-year-old young woman. So remember the age of the patient, the gender. Came to the gynecological clinic with complaints of irritability, tearfulness, headache, nausea, occasional vomiting, pain of the heart area, tachycardia, attacks, memory impairment, meteorism, and these signs appear usually 6 days before menstruation and disappear the day before during its first 2 days. On vaginal examination, the uteri and the uterine appendages are without any alterations. Alright, so the answer here is premenstrual syndrome, which is a bit understandable. Why? Because first of all, we have a fairly young lady who has no any organic changes, because on vaginal examination, uterus and uterine appendages are without any alterations. Secondly, you can notice that the myriad of symptoms that this patient has seem to have a cyclical appearance, which would be more related to the menstrual cycle in one way or another. So in general, premenstrual syndrome refers to physical or emotional symptoms that may occur 1 or 2 weeks before a woman's period. So these are the symptoms that were mentioned, which is why the answer is going to be premenstrual syndrome. So that one is easy to remember. Alright, so we have yet another question on fluorine as the answer. Alright, so this question is also another cramming question. I won't waste much time on it because I couldn't find a lot of information on it. Anyway, so examination of a group of persons living on the same territory revealed common symptoms such as dark yellow pigmentation of both dark yellow pigmentation of the tooth enamel, so dark yellow pigmentation, diffuse osteoporosis on bone apparatus, diffuse osteoporosis, ossification of ligaments and joints, so ossification of ligaments and joints, and then functional disorders of the central nervous system. This is maybe caused by an excessive concentration of which of the following in water. So, as mentioned, the answer is fluorine, but reason being that fluorine toxicity is a condition that occurs when fluoride levels or the fluorine ion is elevated. So, usually in lower concentrations, fluorine is not as toxic as it appears, but a large consumption of fluoride would cause various symptoms as mentioned above. And the symptoms are as follows as well. Alright, so for now, that brings us to the end of our session. I would only be doing these questions for today. Join me next time as I explain the other questions. Thank you very much for your attention. I hope you had a great study session. Bye bye.